Greetings and a very warm welcome to everyone. I am Kashish, the assigned moderator from DentalNet, and it is my proud privilege to extend a heartfelt welcome to all the delegates joining us from across the country. We are indeed fortunate to have the valuable support of esteemed doctors, and I express my gratitude to each one of you for dedicating your time to be with us today. DentalNet is a dedicated all-in-one medical content platform designed exclusively for dental professionals, and our mission is to empower dentists, hygienists, dental specialists, and students with cutting-edge evidence-based knowledge to elevate patient care and foster ongoing professional growth. And at DentalNet, we bring together a nationwide network of dental experts to share their knowledge, clinical experience, and practical wisdom. So now I would like to extend a special welcome to today's distinguished speaker, Dr. Saikat Chakraborty sir. Sir is the Chief Oral and Maxillofacial Pathologist at Dentoscope Panchkula, holding BDS, MDS and PGDHA qualifications. He is an active member of several professional organizations including POPMA, IDA Mohali, PDPA and the Red Cross Society Panchkula. Dr. Saikat also serves as Auditor General of POPMA, reflecting a strong commitment to oral pathology, healthcare leadership, and professional excellence. And before we dive in, allow me a moment to introduce briefly about POPMA. Practicing Oral Pathologists and Microbiologists Association is a national professional organization dedicated to promoting and advancing specialty of oral pathology, oral microbiology, and diagnostic science in India. The association actively works to strengthen and expand oral pathology practice by enhancing professional recognition, creating academic and diagnostic opportunities, supporting policy advocacy, and fostering collaboration among oral pathologists, clinicians, researchers, academicians, and laboratory professionals. Through continuing education programs, study clubs, research initiatives, public awareness campaigns, and professional networking platforms, POPMA strives to highlight the critical role of oral pathologists in disease diagnosis, oral cancer detection, laboratory medicine, and patient care. Under the leadership of Dr. Bhuvan Nagpal, POPMA is committed to building a stronger future for this specialty while promoting excellence, innovation, and evidence-based practice in oral and maxillofacial pathology. And today, sir will be talking on the topic non-healing oral ulcers, biopsy, monitor, or refer. So, sir, I welcome you wholeheartedly to our platform DentalNet, and over to you. Thank you very much.
Right, thank you. Am I audible?
Yes, sir, you're audible and visible.
Audible and volume is good enough? Can I start?
Yes, sir. Yes, sir.
Right. So at the outset, I would like to first of all thank DentalNet for giving us this platform to talk about certain diseases in the mouth, which are of importance. And thank you for this beautiful introduction. I am the Auditor General. I serve as the Auditor General of this association called POPMA, which is relatively a new association, and we are sort of trying to thrive into this fraternity of dentistry in the private practice. Um, Dentoscope is my center, which is primarily an oral pathology center. I um, have my practice on diagnosis and treatment of oral ulcers. Thus, that justifies this evening's topic of non-healing ulcers. Should we biopsy it? Should we keep monitoring it, or should we just refer it? So, whenever we talk of non-healing ulcer, the first thing that we should know is what is an ulcer, what kind of presentations that does a mouth ulcer, what different kinds of presentations can a mouth ulcer show, or an oral ulcer show, um, and would also try to understand the pathophysiology of those ulcers. As I've mentioned in this last line of my slide, most of the dental surgeons, when they get any oral lesion or an oral ulcer in a patient on their chair, the first instinct is to refer it in the first go. without really diving into it, without really understanding what we do about it. The easiest way is to just refer it to some higher center, and they might do whatever they want to do. Whereas the domain belongs to us, at least to do some preliminary examinations, to do some preliminary tests, and maybe form a provisional diagnosis. My personal feeling, maybe because our eyes do not see those lesions, as I've mentioned, that in addition to the dentate tissues, equal emphasis must be given to the paraoral structures, mucosal surfaces, like buccal mucosa and tongue. If you see an ulcer, dive into it, um, train your mind about knowing that ulcer, and your eyes must see those ulcers, and then before you refer, know why you are referring. So these are a few questions that come in our mind whenever we are dealing with any kind of ulcer. That what is a non-healing ulcer? How do we designate an ulcer a non-healing one? Why is it there? Why has it happened? And now what do I do about it? Should I refer? Should I biopsy it? When do I biopsy it? How do I biopsy it? Or should I just keep monitoring with some kind of over-the-counter pharmaceutical drug? Um, First things first, to start off with, whenever you see an ulcer, as we have been told in our, we have been taught in our academics, that the basic steps of history taking and examination would lead you to understand the nature of that ulcer or whatever the presentation is. So, what is an ulcer? If we go by the clinical definition of an ulcer, any ulcer is a clinical lesion which is characterized by the loss of epithelium. If there is no epithelium, there is a raw area, that's an ulcer. But then we get a lot of patches, macules, and plaques. So, this is an ulcer in front of you. Um, are these photos visible? Can I get a feedback from the moderator? Are these photos visible?
Yes, sir, it's visible.
Okay, right. So, if this is the presentation in a buccal mucosa of a patient in your dental chair, so this is an ulcer. Is my cursor visible here as a pointer?
Yes, sir, the cursor is
Right,
also
right.
visible.
Thank you.
Thank you very much.
Okay, thank you. This presentation is also an ulcer. So, what is the difference? Why has this happened? Why has this happened? What are the clinical features? So, first of all, this is an ulcer. This is a patch or a macule. Now, this is something which is a change in the nature of the epithelium, but not raised. Again, this area. This is a plaque. Broadly, as an umbrella term, whenever we get these cases on the dental chair, we umbrella classify them as ulcers. For example, when we are talking to any of our fellow colleagues to discuss about it, we'll say ulcer. No, that was a plaque. That is a macule. This is a plaque, which is a white kind of a patch, but raised from the surface. So this is again a papillomatous lesion on the ventrum of the tongue. Again, this is a round annular kind of a presentation. So if the point to show all these photographs is that whenever you see these kind of presentations of any change in the oral mucosa, you can form a provisional diagnosis. That typically, if I go back, this kind of a raised plaque like thing, white patch, your mind would automatically start thinking of candidiasis. Again, if we see this kind of a annular kind of a presentation of a mucosal change on the dorsum of the tongue in the various areas, you might start thinking of geographic tongue. This is a ulceroproliferative kind of a lesion, where now you will have to find out why has this happened. So the point is, whenever you know that what is the kind of the oral lesion, what is the presentation of the oral lesion, you automatically start to form some kind of a provisional diagnosis, and that is the first step, that form a provisional diagnosis to actually decide whether to biopsy or to refer. So if the patient is presenting with any kind of a mucosal disease, what are the common chief complaints? One of the common chief complaints is pain. The patient would have pain. The patient will come to you, open the mouth, and say, "I have an ulcer in this area. I have pain." You see that ulcer and whatever it is. And then stomatoparosis, which means burning sensation while eating food, which is not spicy or that kind of a food where no other family member is complaining about the spiciness of the food. I'm not able to even a simple dal or a simple sabzi, and I feel a lot of burning sensation in my mouth. So that can be one chief complaint. And one of the important things is incidental finding, where, as I keep emphasizing upon, that our eyes should look for the lesions, but before that, our mind should know about it. Incidental findings: there would be certain lesions or changes in the mucosal surface of the oral cavity where there would be no symptoms. It will be an asymptomatic thing, and it will be an incidental find. The patient might uh, come to you with the chief complaint of a dental pain, and then you suddenly see a white patch or a macule along the buccal surface or on the gingiva. So these are the incidental findings. So once we are done with hearing the chief complaint, so we need to inspect. Where is it? The site? How big is it? What is the spread? What is the color? Most importantly, what is the duration? The duration is, sometimes if there is a asymptomatic kind of an ulcer in some patient's mouth, they might not give you a proper duration. They will tell you the time when they noticed it. That doesn't mean that the lesion presented in the mouth on that day. Maybe it was there a month back also, but the patient noticed it at that time. Usually, these kind of, usually if there is an ulcer which is painful, the patient will give you an exact date that yesterday I was brushing and then I hit my brush in my cheek and then the ulcer was there. So please treat it. So duration is important, which you need to ask whether the presentation is unilateral or bilateral in the mucosa, or whether the lesion is scrapable or not. So whenever there is an oral ulcer or an oral lesion which presents with pain, acute pain. So we must think of some acute stage kind of a disease. For example, maybe a traumatic bite, or maybe an injury with a toothbrush, or an abscess ulcer, which is very common, especially in teenagers or in somebody in 20s or 30s. Stress ulcer, most commonly known as stress ulcer, viral infections, those would be painful, and we are not still inspecting the lesion. It is just the whatever the patient is telling us about it. Okay, so for example, again, this lesion, now this is an ulcer, this is the loss of epithelium if it is clear hair. Now if you see very closely, there is something called an inflammatory or an erythematous halo around it, and it is painful, it is extremely painful. I mean, I was not able to touch my mouth mirror hair, it was that painful. Okay. So painful ulcer, 3 days history, young patient, maybe a history of a cheek bite or some kind of an exam stress. You don't really need to spend too much time about it. You have your diagnosis. Acha, there is no fever. If there is fever associated with any kind of an ulcer, think of some kind of a microbial etiology, maybe bacterial, most commonly viral. So once you decide on this, once you come down to the conclusion, then you have your provisional diagnosis that this might be an abscess ulcer, and then you have your treatment. So you don't need to biopsy it, you don't need to refer it, you need to prescribe some medicines, and that's it. Okay. So if it is a the complaint is stomatovirosis, there is a burning sensation in my mouth. Think of immune mediated conditions. Now this is a very very typical picture of one condition called oral lichen planus, and these white striations, as we have read it in our books multiple times, Wickham stria. So this is a presentation. Now, you don't even need to touch it. We don't even need to now decide whether we should biopsy it or not. But our mind should know how lichen planus presents. The patient is giving a history of stomatoviruses, some kind of precipitation of stress, and this is the presentation. You have your provisional diagnosis with you, oral lichen planus. Now you can decide whether I need to treat it if I know what is the treatment of lichen planus, or should I call some specialist, which means referring. But now you know that I don't need to biopsy it. I've already decided upon what the condition is. Now, when there are certain lesions in the mouth which are the incidental findings, the site becomes very important. For example, hair. Now, this is a kind of a growth with a central ulceration. This was a female patient, and when now there has to be some reason why it is there, and it was not that painful. Um, we could designate it as a asymptomatic kind of a lesion. So then we see here. Now this is a third molar which is completely decayed, 8, and then there is 7 here, and there is this mesolingual wall of the 8 which is there. So whenever the tongue goes back into the physiological position, this area keeps rubbing here. So this is a very I mean yeah, this is a very potent source of a slow chronic trauma to the soft tissue, that is the lateral border of the tongue. Very important site. Chronic trauma for a long time can give rise to cancerous lesions also. So at least now, by seeing that, now you palpate it, whether I'll talk about it later, that whether it is indurated or soft, and then you see the lesion. So now you know that the lesion over here is because of this. So this is the etiology. You treat it. You extract this thing out. You extract this thing out. You give it time to heal. If it heals up, fine. If it doesn't heal up, do a biopsy. So the idea to put this picture is to make you understand that look in first of all the history of the patient, the presentation, and how it is going here. This is the etiology. This is due to the chronic trauma. Again, this is a lesion. You can actually see the indentation of the tooth impinging upon here from this side teeth. So this is the etiology. Now, once you know the etiology, you can designate this as a ulceration because of chronic trauma. Then you further decide whether to biopsy or not. But then you are able to reach to a provisional diagnosis. So this is again a white kind of a patch, completely asymptomatic. Left buccal mucosa, completely asymptomatic. The patient didn't have an idea that he has such a lesion in the mouth, leukoplakic kind of a lesion, pebbly appearance. This is because of tobacco quid, canny placement in this area. And the same thing here. Now, problem with these lesions is normally if we do not have if our eyes do not check it and our minds don't know how to deal with it, you just do the rest of the dental treatment here and send the patient. The patient doesn't know that he has a white patch here. He also doesn't know that it is because of the tobacco placement. So he'll keep placing tobacco and this thing will keep growing bigger and bigger. One fine day, it will turn into a carcinoma. And by now, we have missed the train. Now, carcinoma has a very defined protocol how we treat carcinoma, but we can actually treat it here itself if we know how to treat it. So this is a tobacco, again, canny-induced white patch. Retrocommission of the lip, it is a very important site if the patient is a smoker, which you have to take history of. Multiple sites. One of the very common lesions, this is the whole gingiva is involved. One of the very common conditions where multiple sites are involved with white patches or growth is a proliferative varicose leukoplakia. So if you see this kind of a picture, you are able to form your provisional diagnosis. Whether the lesion is unilateral or bilateral, if the lesion is the common bilateral lesions are linea alba buccalis. I have mentioned it, linea alba buccalis there, but it is a physiological kind of a white patch. You don't deal with it. You just keep it as such. Lichen planus again. This was the picture which I had shown before. Now the other part of the cheek looked like this. Sorry. So metacranous kind of a presentation lichen planus has. Plus this lady was complaining of stomatopirosis. We can also see some hyperpigmented areas, which is usually seen in lichen planus in a healed lesion because there is a melanocyte deposition in the basal layer. So bilateral presentations, stomatopirosis, a female with some kind of a stress, you can designate it as a provisional diagnosis, lichen planus, working diagnosis of oral lichen planus. Palpation. Palpation means, I'm sorry, a digital palpation. Touch it with your fingers and see whether it is soft. This was a soft lesion. This was an indurated lesion. Induration is bad. Induration means the thing is proliferating inside. Most common presentation is a carcinoma. So this we don't even need to think twice. This is a carcinoma. This is soft, so some kind of a soft tissue growth or a tumor, whatever. But clinically, we need to digitally palpate that particular lesion and then designate it as soft or firm or indurated. Escapability. This lesion was not scrapable, which means this white change is happening from within on the surface mucosa. This was scrapable, which means the thing has not started from inside, something has deposited over. Sorry. So this is a leukoplakic patch, but if it is scrapable, the most common scrapable lesion in the mouth is candidiasis. You can immediately think of candidiasis, and when you make a working diagnosis of candidiasis in a patient or a presentation like this, now you know what to ask, because candidiasis will not happen in a healthy individual, whether the oral hygiene is good, whether the patient is systemically healthy, things like that. But anyways, now you know the treatment of candidiasis, antifungal, and you're done. But make sure that you scrape it off and see whether the underlying mucosa is fine or not. This case will be discussed later also, but just at the outset. And if there are red and white ulcers in the mouth, the red and white lesions in the mouth, which are categorized as leukoplakia, which means a white patch, erythroplakia, which means a red patch, and both mixed red and white areas is erythroleukoplakia. So this is actually a stage that first of all there will be white patch. If it doesn't get treated, doesn't get managed, it might end up with a reddish area, even bad. And then there would be a speckled appearance. We also call it a speckled lesion. Speckled lesion means part red, part white. So whenever you are faced with a red or a white lesion or a patch or an ulcer, where you now have to decide what to do. These are some things which you need to ask. Risk factors. Is the patient using any kind of tobacco? For that, you also need to know the various kinds of tobaccos, smokeless forms like khani, gutka, and things like that, or smoke form like a cigarette or a BD. And if there are malpose teeth, very common in today's youngsters, where usually the eights are misplaced. They are either in a buccal version or a lingo version. So in a buccal version, they might give a chronic ulcer in the buccal mucosa. In a lingo version, they might give a chronic ulcer in the lateral part of the tongue. In old patients, ill-fitting dentures. Normally, the old people with, or anybody who is using, nowadays we do not have this problem most of the times because now everybody is going for implants. But if there are dentures in the mouth and it is a ill-fitting kind of a denture, it keeps forming a very slow kind of a ulcer which the patient doesn't notice. So any ill-fitting denture, please examine the mouth properly. Duration, any white or a red patch or an ulcer which is not healing for more than 2 weeks in a systemically healthy individual. We all know diabetes mellitus delays wound healing. So if it is diabetes mellitus, give it time. Ask the patient to take care of the sugar level. But without any etiology, without any systemic illness, if any particular lesion is not healing for 2 weeks, 2 weeks from the day you have seen it, maximum you can take it for 1 month. So if the healing has not happened for 2 weeks to 1 month, you need to intervene. Tenderness, you palpate it, and you, like for example, an aphthous ulcer will be very tender to touch, whereas a chronic ulcer will not be that much tender, or a white or a red patch or a leukoplakic patch because of a tobacco induced lesion will not be painful at all. So painless the lesion, poorer the prognosis. And if there is induration, even bad. So if there is pain in any kind of a ulcer in the mouth, we are happy because we know the patient will come for the management and we can manage it. But if it is painless, then you'll have to put your thinking caps on. Site I have already mentioned. There are certain vulnerable sites like the lateral border of the tongue, the gingivobuccal sulcus, which is also known as the vestibule, the retrocommissural lip, especially in smokers. If the lesion is unscrapable, well, you have to intervene. If the lesion is scrapable, think of candidiasis. Suddenly, Um, mobile tooth, mobile teeth can be there in a trauma. Somebody gets a punch. That's okay. We have the reason. We can splint the tooth and get away with it. Periodontitis. But if none of these are there and suddenly the tooth gets mobile, do not jump into extracting the tooth. There may be something inside the bone that is destroying the supporting tissues of the tooth, and there is a sudden mobility. Always check for those things in an X-ray or in a radiographic image. So red or white lesion in a vulnerable site more than 2 weeks duration, your alarm bells should start ringing. Plus, if it is painless or with a minimal pain and there is induration which is hard to touch, stony hard to touch, the bells now, those alarm bells should now start ringing louder. And if there is no etiology, for example, if there is no fever, if there is no trauma, but there is a risk factor which is tobacco or a malposed tooth, then you must intervene. So, if the lesion is present without any obvious etiology and there are risk factors, perhaps we are looking at something called an OPMD. An OPMD is a oral potentially malignant disorder. Initially, we used to term it as oral potentially malignant lesion and disease. Now it is an umbrella term, which is what now oral potentially malignant disorders, which have increased risk of malignant transformation. The common ones are, as I've mentioned before, leukoplakia, erythroleukoplakia, proliferative verrucous leukoplakia, oral thrush, candidiasis. Again, candidiasis, this white patch in the ventrum, which was scrapable. Oral submucous fibrosis, oral lichen planus. Now there are studies which are showing that it might not be a pre-malignant disorder, but for all practical purposes, we still keep it as an OPMD and we treat it. So now, if we combine all the factors, like we take a proper history, we see the sites, we do the examination, we are, as we have seen, we were able to come up with a provisional diagnosis for every kind of a mucosal disorder. And if we have been able to form a provisional diagnosis, we should also be able to form a tentative treatment plan. Like if it is symptomatic, go for the symptomatic treatment, like a painful ulcer and aphthous ulcer, dologel, any obtundant kind of a paint can do NSAID to take care of the pain and give it time. So this thing I would like to really mention, triamcinolone, which is marketed as Canacort. Canacort doesn't work in every white lesion. You cannot just see a lesion and say, "Ki, oh, let's do the RCT today or let's do the extraction and put an implant today for this white patch." No history, nothing. Just give Canacort, and then the patient goes and comes back after 2 weeks. Nothing has happened, no improvement, and then how does Canacort work? The Canacort doesn't work in every situation. Um, Rather, the detrimental use is once you give Canacort is a topical steroid. It will reduce a very little amount of underlying inflammation. The patient might feel good for a few days, which he might mistake as I'm healing, and then he doesn't. Uh, if he doesn't get a complete remission, he will not visit the doctor because कोई बात नहीं, I'll still apply and आज नहीं तो कल मैं ठीक हो जाऊंगा. So triamcinolone doesn't help. You should know where to use triamcinolone or Canacort. Um, if in a fix, go for biopsy. So this is the importance of biopsy. Most of the public, which is the patients, think that biopsy means I have cancer. In my experience, the bad part is even many clinicians think so, that we biopsy only a lesion which we think is cancer. No. So when do you do your biopsy? If your clinical aids and your radiological aids fall short to provide a definitive diagnosis, there is a white patch which is asymptomatic, and there is a risk factor like a tobacco induced, like the patient is using tobacco. Okay, so your Canacort will not help, your Dolagel CT will not help, your NSAIDs will not work because there is no pain. So your clinical tools have not given you a diagnosis. I mean, not healed the area. So what do? You do a biopsy. Okay. So what kind of biopsy? We'll discuss about it later. Lesions where the symptomatic treatment cannot be rendered. The same example. Now you cannot do any symptomatic treatment, so biopsy it. Chronic unhealing lesion for more than 2 weeks. Any inflammatory lesion that does not heal after 10 to 14 days of removing the etiology. Let's say there is a young patient with a buccal version of 3.8, and then there is a lesion in the buccal mucosa, a chronic ulcer presentation. So what you do is in the first visit you check out the 8, you remove the 8 and let that ulcerative area heal, because now the etiology is gone. But after 2 weeks you see that the lesion is still not healing. So that is when you should decide to do a biopsy. and then any red or white lesion. Why do we do a biopsy? What are the advantages of doing a biopsy? It provides you with a final diagnosis, which would help you decide upon the final treatment plan, comes up, and also confirms your provisional diagnosis. You see that it is leukoplakia. In a histopathology, the report comes as hyperkeratosis. So it confirms your provisional diagnosis. So there are no absolute contraindications, relative ones being compromised health, proximity of the lesion to the vital structures, floor of the mouth, anatomical variations like lineal buccalis, which means that biopsy can be done chairside. So, what are the various types of biopsies? Excisional, incisional, punch, needle, fine needle aspiration, and exfoliative cytology. Exfoliative cytology, where we see the cells, it is different than the scraping part, because exfoliative is which is exfoliating by its own. Like you collect the saliva and then you do a centrifuge, you see the cells which are exfoliated, look at them. FNAC, you put a needle. Punch, you put a punch and take the thing out. Incisional, where the lesion is the size of the lesion is more than 1 centimeter, you take a part of it, see the nature of it. If it is not cancerous, remove the rest of the lesion. Excisional, if any lesion is the maximum dimension is 1 centimeter, remove the whole lesion. So the lesion is, I mean, when you remove the whole lesion, you therapeutically also you are good, because now the lesion is not there in the mouth. Diagnostically, you give the whole thing to the pathologist and he gives you a report back. So that is an excisional biopsy. That is what I have written here. Last 2 points important. In incisional biopsy, try to take the healthy margin also, because that would help the pathologist to compare the disease and the normal mucosa. Sometimes adjunct techniques might help. Usually, the adjunct techniques are, we talk a lot about it. Um, I normally use the one which is in the rightmost corner, that is the toluidine blue. Um, we have other these things also, which are which work on autofluorescence and chemiluminescence. In India, economically, if we see the economics part, the toluidine blue staining helps a lot. For example, this kind of a lesion where, as I had mentioned, when we do a toluidine blue staining, now you can see a very deep kind of a hue after you do the counter staining. And then you know that if there is a retention of this hue of blue, you need to biopsy it. So now we know that when are we monitoring or when are we referring. Sometimes there are clinicians who think that I know this is to be biopsied, but I am not very comfortable with the procedure. Well, it always has a learning curve, but then you know that you have taken care of the lesion. Whether you now refer the patient for biopsy to some other specialist, that is a different issue. But if you decide to do the biopsy for yourself, these are certain tests which you need at hand, like any other minor surgery. A basic set, I this is my set, so I have taken that example. There is no punch here. I usually do not do a punch because I feel that it macerates the tissue, and as a pathologist, I don't like the macerated tissue under my microscope. Rather, I'll give a clean cut with the blade. This is the most important part. If you decide to do a biopsy, if you do not have any armamentarium in your operatory, that's fine. But if you do not have formalin, please do not biopsy. Please do not venture into this process of biopsy, because I have had many. I practice as a oral lesion expert, and I get a lot of calls that I have excised the lesion, but now how do I send it to you? Okay, then put it in the formalin, but we do not have formalin with us now. Then there are lots of things that, can we put it in whiskey, can we put it in the patient's mouth, can we put it in ice? No, none of the fixatives works. If you do not have formalin with you, then you do not biopsy. Okay. Because once, now the thing is, you cannot do like that ki you do a biopsy and then you call your pathologist that, look, I have taken out the lesion, I do not have formalin, please send formalin. No, that doesn't work that way. Because once you cut the tissue out of the main arterial supply, you just have 2 minutes to put the tissue into formalin, because then autolysis will start. So in 2 minutes, your pathologist cannot provide you with formalin, and he is not bound to provide you with formalin unless you're working in a hospital. In a clinical situation, in private practice of dentistry, a pathologist is not bound to provide you with formalin. On a friendly basis, he or she can. So it is your, if you decide to venture into biopsy, please make sure you have formalin, because this is one thing which I have faced a lot, that we do not have formalin. We have cut the tissue. Now what do we do? I don't know. You need to have formalin with you. This is how you pack it with an open mouth. Um, some examples of biopsy. This is the papillomatous. This is the papillomatous lesion. Greatest diameter is 1 centimeter. So it was painless, and we needed to remove it and then do a biopsy. So we do a excisional biopsy with a healthy margin around, and then we do a primary closure. We send it to the pathologist. Since this case is done by me, I send it to myself and then I observe it under the microscope. But then, if you are not a pathologist, please send it to an oral pathologist. In a lesion like this, where it is almost more than 1 centimeter, and you decide to do an incisional biopsy, usually this is one of the good and practical ways of placing your incision, a wedge shaped incision where you also include the healthy tissue. This is how we biopsied it. And if you are taking multiple tissues, please label them with a suture. That if, for example, in a tongue there are two lesions, one in the anterior part of the lateral border of the tongue, one in the posterior part of the lateral border of the tongue, you cut it and then you suture any one, and then you, in your requisition form, you write that the sutured tissue is the posterior part, so that the pathologist knows. Because when he takes it out of the formalin, the two tissues will look alike. A few examples. This was the lesion. We have a habit of using toluene blue. We did a toluene blue. It demarcated the lesion nicely. We did an excisional biopsy because it was less than 1 centimeter. Unfortunately, it turned out to be a squamous cell carcinoma. The ones who are not the pathologists in the audience, this is how a squamous cell carcinoma looks under the microscope, and then we refer it. Here, when you refer the patient, your referral has a good solid base, that you're referring the patient because you had tried to, you ventured to treat the lesion, but it is now an oral carcinoma where the treatment protocol changes, because now we have to see the clear margins and lymph nodes and all that. So what you do, you refer the patient to a higher center along with the slides and the blocks, so that they can review it without wasting time. And then they have and then they will not render the patient to another biopsy. Otherwise, if you simply, now if we take the example, and if we would have simply referred this patient to a higher center without doing all this, they already have a very large patient base. So what they would do is, they would first of all try to do a biopsy here, and biopsy is a minor surgical procedure. The patient will get a very back date, a long waiting wait would be there for a biopsy. So you do this part and then send the patient, so that the patient is not subjected to another rebiopsy. Your pathologist will give you the slide and the blocks. The patient will submit it to the higher center. They will see it in 2 days. They will decide that, okay, fine, this is colorectal carcinoma, and we will be taking him or her up for the major surgery. The time limit reduces. Again, the same thing, the same lesion. We did a incisional biopsy here. We did it all in blue. Now you can see the kind of a retention. This also came out to be a squamous cell carcinoma. We can see the mitotic bodies here. The ones who are pathologists, this is for them. Lots of mitotic bodies. Plus, this is carcinoma, pleomorphism, and all those things. So again, this patient is referred. Now, this example, there is a growth which was soft. It was irritating the patient, should not be there. We removed it. It is a palate. We cannot do a primary closure. Secondarily, it will heal. This came out to be a very beautiful, benign fibrolipoma. Also, you should know that if you are sending it for the biopsy, what are the histopathological terms and what does it mean? If your report, the pathology report says low grade dysplasia, then you make sure that the lesion is completely out of the mouth with healthy margins. If it is hyperkeratosis, again, complete excision or keep on observation. When we say keep on observation, which means monitor it. Hyperplastic epithelium, keep on observation, that it should not grow, because you have already cut the epithelium and have sent to the pathologist. Hypoplastic epithelium, which means there is no very definitive pathology inside. Immune mediated disorder, again, appropriate management with steroids or tacrolimus, um, or dapsone, whichever is your protocol. High grade dysplasia, severe dysplasia, carcinoma in situ, or full fledged squamous cell carcinoma, or varicose carcinoma, or PVL. These three categories refer to the specialized higher center with proper notes, what you have done, and the pathology report of the incisional biopsy, along with the slides and the blogs. This will do a lot of good to the patient, because now if any one of these is diagnosed in histopathological examination, the patient already has lost a lot of time. Let's not make him lose more time by simply referring, and then they will do an incisional and this and that. And if it says inconclusive, need deeper biopsy, don't fight, just take a deeper biopsy. So some examples, like this was a lesion which looked not very good. We did it already in blue, but when you did a biopsy, it came out to be a moderate dysplasia. So we simply did remove the whole thing, and the patient was completely healed. This we know. I've already like. So don't get fooled by the size of the lesion. This was bigger than this, but this was moderate dysplasia. This was squamous cell carcinoma, well differentiated squamous cell carcinoma. This was the lesion which I was talking about, raised lesion, plaque-like. But when we scraped the part, the underlying area was erythematous. So we decided to take two samples from the underlying erythematous area from here, which is the posterior buccal mucosa and anterior buccal mucosa, and this was the histopathology. This was the histopathology. Any pathologist or oral pathologist sitting in the audience would know this was carcinoma in situ. Again, we refer with proper paperwork so that the time is not lost. So now reiterating, these were the three questions we started off with. Now, can we answer them? What is a non-healing ulcer? Any ulcer or a lesion that does not heal for more than 2 weeks, even after removing the etiology in a systemically healthy patient, is a non-healing ulcer. You do plan a biopsy, and then you decide after reading the report that whether you keep it on a monitoring kind of a thing, or you refer them to the higher center. Why is it there? We kept on talking
Hello, can you hear me? Hello, Dr. Saikat, can you hear
Yeah,
me?
I'm there actually. We had a I mean
Your screen
it's
sharing got
raining over
stopped.
here, and we had a loss of connection. We had a loss of electricity, and I just lost the connection. Am I back?
Yeah, yeah, yeah. No worries, sir. You can again share your screen.
Wait, is it there?
It's it's still yet to reflect.
I'm so sorry.
No worries, sir.
Now
No, sir. Yeah, now your screen is visible. Can you just make it in the slideshow mode?
done?
Uh-huh. Yeah, this is the slide, and you were in this slide only, right?
Yes, yes. Can you see these things appearing on the screen? Any ulcer, chronic
Yeah, yeah, yeah.
trauma?
The animations are working, sir.
आ गया आ गया आ गया आ गया आ गया जब बैठ बैठ
Yeah,
animations are working.
yeah, yeah, yeah. Yes, sir.
So I was in where, why is it there, right? I'll start from here.
Yeah, yeah, yeah. Sure, sir.
Okay, so chronic trauma and habits. That is the reason why that particularly habits. When I say, I mean tobacco using habit. And what do I do about it? First, form a provisional diagnosis. How to form a provisional diagnosis? We have discussed it at length. And then manage accordingly. If your provisional diagnosis says that this is a leukoplakia, which is painless and there is a risk factor and induration, go for biopsy. If it is a painful thing, tender, young patient, not a long history like 2 or 3 days or something, do a symptomatic treatment. Antivirals can work, but generally, good rest and hydration will tide over the viral load. Um, if you're not able to, sometimes, I mean, for example, oral lichen planus. In a oral lichen planus, there is a white lesion or a red lesion that has developed. Go and biopsy it. Not necessarily it will come out to be carcinoma, but you will know what it is and what do you do from here. If it confirms, like for example, if it confirms oral lichen planus, you initiate the treatment of oral lichen planus. So most mucosal lesions are asymptomatic. Patient will not know the sinister implications of these. For example, the leukoplakia in a smoker. It is the dental surgeon, us, who has to emphasize on the potential risks of these lesions. In a high quotient dental procedures like implant prosthesis, which now every dental surgeon is doing, or a minor surgical procedure, the presence of mucosal lesions might mean an undiagnosed underlying condition that might affect the treatment outcome. So, any mucosal lesion should be managed prior to or simultaneously with the other procedures, but never following them. That I put an implant and then I take a biopsy. Oh, now if the biopsy says leukoplakia or a tonsil carcinoma, what do you do? The patient will not give the money back. So, this is pretty much the end of my presentation. The photograph on the right side is my working area, and the left side is my professor, Professor V. Ramesh from NDPGI, because of whom we are doing whatever we are trying to do in the society. So, thank you, one and all. Thank you for your patient listening. And this is where I end my discussion. And if there is any question, I'm ready to take them. Shall I stop sharing?
Yeah, yes, sir. Thank you so much. Just allow me a moment. Yes. So thank you so much, sir, for your wonderful talking presentation. It was actually very lucid. So now, sir, moving forward with the questions. The first question is from Dr. Ananya Sharma, and she's a MDS resident in Oral Medical and Radiology, Jaipur, Rajasthan. And she has asked, shall I proceed with the
Yes, yes,
question?
yes, yes. Hmm.
Okay. She has asked which clinical feature should alert dentist that a non-healing oral ulcer requires further investigation.
Which
Yeah,
which
I'll
clinical
repeat.
feature? Hmm.
I'll repeat. Which clinical features should alert dentist that a non-healing oral ulcer requires further investigation?
Okay. Asymptomatic lesion, if it is not paining, number one. Number two, induration. And number three, vulnerable site. For example, if it is in the lateral border of the tongue, please go ahead and perform a biopsy. Are you there?
So, thank you so much. So
Hmm.
moving ahead with the next question is it's from Dr. Rohan Mehta, and he's a general dental practitioner from Ahmedabad, Gujarat, and he has asked how long should an oral ulcer persist before considering biopsy or specialist referral?
2 weeks. 2 weeks to 1 month max.
Moving ahead with the next question from Dr. Sneha Iyer, and she's a MDS resident in oral pathology, Chennai, Tamil Nadu. And she has asked, what are the key histopathological findings that help differentiate reactive ulcers from malignant lesions?
Oh, there are a lot of them. I mean, I can take a 1 hour webinar on it. I don't think it is really in the purview of now the kind of time we have to do. But then I'll give you a few answers. One is presence of dysplastic cells in the epithelial width, presence of now there are five cardinal signs of dysplasia. I'll just tell them, and further discussion can be done later on, because as I mentioned, it can be a 1 hour topic. One is pleomorphism, both cellular as well as nuclear. Second is increased nuclear cytoplasmic ratio. uh, the third is presence of atypical mitotic bodies, either by appearance or by positioning. And the fourth is loss of polarity, and the fifth is presence of any tumor giant cells. If these five things are there, then you might be looking, you are looking into a dysplastic or a carcinomatous kind of lesion.
Thank you so much, sir. So, moving ahead with the next question, it's from Dr. Vivek Banerjee, and he's a oral and maxillofacial surgeon from Kolkata, West Bengal. And he has asked, what factors should clinicians consider when deciding between monitoring, biopsy, and immediate referral?
Monitoring, comma, biopsy, comma, immediate referral.
Yeah.
Biopsy, as I told you, if the lesion is asymptomatic and you're not able to render any kind of a treatment, go ahead and do the biopsy. Monitoring is like, for example, lichen planus. Lichen planus, you have diagnosed and now you have started off the patient on some kind of a steroid or something, and then keep monitoring them. Immediate referral, I don't know. Immediate referral, if you're not really confident with the procedure of biopsy, then you refer immediately. But having said so, I must say that somebody who is into private practice in a standalone dental clinic, always, even if you are sort of thinking that this might be a carcinomatous lesion, perform an incisional biopsy. Like, if you think that the lesion is proliferative, it is an ulcer or proliferative growth, why take a biopsy and let's send the patient to the higher center, because in anyways they will take a second biopsy? No, they don't do that. um, because if you do an incisional biopsy, it will be, the patient will get the incisional biopsy done on a very short period of time. 5 days you will get the report, and then if the report, obviously, if it corroborates with your clinical finding of squamous cell carcinoma, now you refer with proper paperwork to the higher center, and along with the slides and the blocks. Now they will not take the patient up for second biopsy. Now they will take 2 days to sort of review the slides and take up the patient directly for a definitive surgery for carcinoma. So you sort of reduce the time for the definitive treatment of that patient to a very large extent, and thankfully for and thankfully for the patient. So that is one thing which I would like to emphasize.
Thank you so much, sir. And moving ahead with the last question for the day is from Dr. Meera Kapoor, and she's an assistant professor from Department of Oral Medicine and Radiology from New Delhi. And she has asked, what are the common diagnostic errors associated with persistent oral ulcers, and how can they be avoided?
Diagnostic errors: persistent oral lesion diagnostic errors. If we do not follow the history, if we do not have a knowledge of how an immune mediated for example, an immune mediated lesion will present in your mouth, those are the areas where you can falter. um, Also, if you do not know what to ask for in a pathologist, for example, if you what to ask for to a pathologist, for example, if you are clinically suspecting a pemphigus, you should know that indirect immunofluorescence is something which is of importance. So when you ask the pathologist about it, you must say that along with the simple histopathology, I also want a indirect immunofluorescence that clinches the diagnosis. So but if you follow these tenets of examination and forming a provisional diagnosis, generally you won't error to that extent that the things might go out of hand. Unless there's a complete error that there is a small lesion which you completely overlooked and it turned out to be a carcinoma later.
Thank you so much, sir. And once again, thank you so much, everyone, for joining. And I hope your doubts have been clear. So, sir, before we end this session, I would just request you to share a few conclusive remarks on the importance of biopsy in suspicious oral ulcerative lesions.
Well, I mentioned the same in my presentation also, but one thing which I would like to reiterate is we do not see what our mind doesn't know. Let us train our mind to know these things so that our eyes can see them. And please go ahead and do biopsies. In cases where you are unable to form any diagnosis, it will help a lot to the patient. And if you are able to plug OPMD in a very early stage, oral potentially malignant disorders, there is a very less chance that the patient will end up to a full-fledged carcinoma in the long term, and that brings down the cancer burden to a large extent in the country.
Thank you so much, sir, for your valuable key takeaways. And here we'll conclude for today. Till then, stay safe and have a wonderful time ahead. Thank you.